up, we'll have Dr. Chen. Will circle back with us, and he's going to talk about acute and attack prevention treatments. Dr. Chen has led actually the way in many of these studies along with Dr. Thakal Waboon on plasma exchange. They have a big study, international multi-center study coming out on that. And then Dr. Chen's early work comparing treatments from patients at Mayo Clinic really led to the discovery that IVIG may be beneficial. And I know many in the audience are on IVIG, and now he's looking to also be involved in clinical trials in both plasma exchange and maybe subcutaneous immunoglobulin. So really is leading the way in bringing treatments to patients. So go ahead, John.
Thanks, Owen. So we've talked about wonderful talk from Dr. Syk Mazurek about acute attacks and how do we diagnose it. So essentially, if you have an acute attack or acute relapse, and we know it's an attack, we're going to be doing acute treatments. And we've talked a lot about these already. So I just wanted to briefly talk about these options just a little bit more in terms of what it entails. So typically for steroids, when we talk about steroids, it's typically IV methylprednisolone. That's the kind of steroid we're typically doing. And it's administered through the IV, and it's 1,000 milligrams of this IV methylprednisolone. It's usually over 30 minutes, and we usually give it for 5 days in a row. Sometimes they'll give it for 3 days, but at least at Mayo, we usually do it for 5 days, especially if it's a serious or a severe attack. And so that's going to be your typical treatment for attacks of MOG, essentially get the steroids in as fast as possible. And then there's another option is oral prednisone, so oral prednisone pills. And so the Optic Neuritis treatment trial, it was interesting. Again, it didn't have much MOG in there, but essentially what it found was that IV steroids quicken the recovery. And then they also had an arm where they gave them low-dose oral prednisone. And the low-dose oral prednisone didn't really help, and it led to more relapses. So the thought was that you have to give IV steroids for optic neuritis. You can't give oral steroids. What we found out, though, is it's not really the route. It's actually the dose. Since then, there's been a couple clinical trials comparing high-dose IV methylprednisolone to super high-dose oral prednisone, and they're equivalent. And so you can give pills by mouth. You just have to give a lot of them. And so what I mean by a lot of them is essentially 1,000 milligrams of methylprednisolone is equal to 1,250 milligrams of prednisone. And the drawback is the largest prednisone tablet is 50 milligrams. So if you are going to be treating optic neuritis or a MOGAD attack with oral pills, it's 25 pills all at once. And so that's an option. It is equivalent. And again, at the time of COVID in 2021, we used this a lot because people didn't want to come to the hospital. And this is still an option that we do for patients who don't have access to IV. Essentially, we prescribe these high doses of oral prednisone. I think Dr. Flanagan had mentioned it. We call it pocket steroids. Essentially, they just have in their pocket in case they have an attack, they can use it. And we'll talk a little more about that in just a little bit, actually right here. So one question is, how about timing of steroids? In multiple studies, again, these are retrospective, but multiple studies have shown that early steroid treatment is better. And we think that's the case, and we found that this as well. And what we think why early steroids helps is with optic neuritis, essentially patients usually have eye pain, and on average, maybe 1 to 3 days before the vision starts dropping. And then the vision tends to drop for 3 to 7 days before it gets to really bad vision. And as many of you had optic neuritis, especially that first attack, we don't know what it is, so it tends to just kind of smolder until they're almost blind by the time we figure out what it is. But what we found is that multiple studies have shown that early steroid treatment is better. And what the thought is if this is your normal vision, let's say 20/20, and let's say this is blind, if you go and then don't get treatment until you're blind, you can get steroids there, and then you can slowly make your way back up. And sometimes you might get back to 20/20, sometimes you might get back to 20/40. We don't know where you're going to fall. But let's say you're at 20/20 normal, and now we know you have MOGAD, so we're looking for bouts of optic neuritis, and you drop to 20/25 and you get steroids. It's a lot easier to get back to 20/20 from 20/25 than if you're 21,000. And so that's why we think early steroids is helpful. And again, for the past actually 5 years now, we've been doing this prospective study where we've been prescribing patients this 1,250 milligrams of prednisone, which we call pocket steroids, that they have access to. So in case they have a relapse, they take the steroids. And essentially, we've been following 115 patients so far over 2 years. And so we've had, about 30 attacks, and not a single patient has had permanent deficits from that attack because they're getting the steroids so soon. So it is an option, but it is a whopping amount of steroids, as you saw. The other big treatment that we have, so again, we're going to treat with steroids. We know it works, but there are some patients that don't respond to steroids, especially that first attack. Because again, by the time we're seeing them, they're either in a coma or they're in a wheelchair or they're completely blind, and we give steroids and it's just not enough oomph to get them better. The next step we have is something called plasma exchange, and you've heard a lot about that, but I just wanted to step through just a little bit more detail so we kind of know what's going on here. But essentially, a lot of these patients need a central line. Occasionally you can go through a peripheral line, but we're essentially taking your blood and taking it through this thing called plasma exchange, which filters out the pathologic antibodies. Essentially, you're flushing out all the inflammation, you're flushing out all the MOG antibodies, and then you're getting plasma back. So it's called plasma exchange. And we think that this leads to much better outcomes, but it is more involved. It often requires a central line. It's often 7 treatments every other day. And so you're essentially getting treatments for 14 days. And again, it's more invasive than IV steroids because of that central line. So we'll use it if we need it, but we usually start off with steroids, and most patients recover. Dr. Smathorn led a wonderful multi-center study around the world where we showed that plasma exchange, especially if given early, is associated with better outcomes. Again, this is a retrospective study, so we've got an upcoming clinical trial for patients with severe optic neuritis, severe transverse myelitis of any kind. Essentially, we'll get randomized to getting plasma exchange right away, and steroids, or steroids alone, and then if they don't recover in 1 to 2 weeks, then they get plasma exchange. And so these randomized clinical trials will really kind of give us that evidence of, does plasma exchange work, and 2, does timing really is it really important or not? But we think it is at this point. But those randomized clinical trials are important. The other treatment that obviously a lot of you hear about and are on actually is IVIG. For the most part, we use this for more prophylaxis to prevent relapses, but sometimes we can use it for acute attacks, especially in children where we don't want to really work with the central line in these little tiny kids. We'll sometimes do IVIG instead, where you're giving a good amount of IVIG. And what it is essentially is you're giving a huge dose of good antibodies. So essentially, you've got these bad MOG antibodies floating around causing inflammation. And what IVIG is, you're flushing a bunch of good antibodies in there that kind of blocks all the receptors and calms things down. And so you're blocking those antibodies from causing damage and just reducing inflammation that way. So that's what we're doing with IVIG, is essentially just giving you a ton of normal antibodies that are normal, blocking those pathologic bad antibodies. So those are essentially our acute treatments. And then now, again, Dr. Mazarek and many others have talked about these attack prevention treatments. And again, the patients that need this are patients who have relapsing disease or those who have a very severe attack and left them with disability from that first attack. Those are the patients we're going to do. But if you've got a single attack and very good recovery, we're not going to put you on chronic treatment because there's only that 50% chance you're going to have a relapse. And we've talked about a lot of these already, so I'm just going to briefly run through them. A lot of patients will put on low-dose prednisone, and it's going to be 10 milligrams or less, because if you're on higher doses of prednisone, it's going to cause a lot of significant side effects, including weight gain, it'll cause diabetes, thinning of the bones, a whole host of side effects. But if 10 milligrams or less, it can still be okay. Then we've got our traditional NMO medications that we use for NMO, like rituximab, mycophenolate, and azathioprine, but we don't think these may not be quite as effective in MOGAD as it is for NMO. And then we've got monthly IVIG, usually at 1 gram per kilogram or more, or weekly subcutaneous IG at 0.4 grams per kilogram. And dose and frequency matter, actually. We've looked at it where essentially if you're on a low dose or very infrequent dosing, it doesn't cover you nearly as much. But if you're on really large doses, it really tends to shut things down. And so if you have, let's say they start you on a very low dose of IVIG at 0.4 grams per kilogram every month, and you have a relapse, that doesn't necessarily mean that IVIG doesn't work for you. You might need that higher dose. And again, we tend to start at 1 gram per kilogram and can even go more frequent if necessary. And then the weekly subcutaneous IG is nice because, again, there you're getting your immunoglobulins every week. So with IVIG, you get this nice bolus, and then after a month, it tends to go back down. And then you've got a nice bolus, and it goes back down. But every time it goes back down, you're at a little bit of increased risk before you get that next dose. With the weekly subcutaneous IG, you're getting a lower dose, but you're getting every week. So you're just kind of keeping that steady state that keeps you safe. And again, we do hope to have a randomized clinical trial for sub-Q IG in the near future, and that's something we're working on. But dose really does matter, and frequency matters. We think that tocilizumab, an IL-6 inhibitor, is very effective and really a treatment that we often do as well. And we're going to hear more about these actually in the next section, but essentially anytime you have relapsing disease, look out for these randomized clinical trials. There's 2 enrolling right now, satralizumab and rozanolixizumab. We think these are going to be very effective, and we're going to be talking about these in more detail in just a little bit. So in terms of acute treatments, steroids, earlier the better. Plasma exchange, second line, if needed. Not that many patients with MOG need it, but I'd say 20% may need it. IVIG is a third-line treatment, and attack prevention for relapsing disease. Any questions?
Hi, Dr. Chen. I don't have MOG, but I've had a lot of experiences with high doses of prednisone, and I have not responded well with the side effects. And I'm curious if I've looked in the past and I haven't seen any research or other options in place of prednisone, because it was developed in 1954. So I'm just curious.
Yeah, in terms of what other options we have than steroids.
And if there's research going on in that area.
Yeah, the reason why we do steroids is because it's essentially the quickest acting. And so when you've got inflammation, we're just trying to calm it down as fast as possible. But like you said, there's a lot of side effects, designed in the 50s, but yet that's still what we're using now. I'm not aware of any steroid equivalents that are being used. But again, there are treatments that are pretty acute, fast-acting, like tocilizumab. Again, as Dr. Flanagan had mentioned, there's some cases of fulminant MOGAD where it's so much inflammation that steroids can't control it, and they've given them tocilizumab, which blocks IL-6, just another cascade of inflammation. They blocked that cascade, and it led to good improvement. Some of these medications, like even rozanolixizumab, potentially could be used for acute therapy. Some complement inhibitors as well. Those are all pretty acute acting. Again, right now we've been using for more, monthly dosing to prevent new attacks. But could some of these be acute treatments? That's certainly a possibility, but still being explored.
Yeah, my question is similar. As you know, I don't have the severe side effects from prednisone that most people have. I have the side effects coming off of prednisone and high dose IV steroids. So I'm kind of a little bit terrified if I ever did have a relapse. I'm having such trouble coming off prednisone now. What would happen to me? Would the medications you mentioned be possibly something to try, or I just don't know what would happen to me, and what I would take to deal with a relapse if I had another one.
Yeah, so when you're coming off the steroids, there's 2 things that are going to happen. One, just coming off steroids makes you feel super lousy, because steroids kind of gives you a lot of energy, and then when you come off, your body takes a while to kind of produce essentially steroids. So your body actually is generating about 10 milligrams of steroids per day just naturally, but if you're on long doses of steroids for over 3 to 4 weeks, your body makes less steroids because it says, oh, your body has it already, I don't need to make it anymore. And so you got to come off slowly, otherwise you have to wait for your body to make more steroids again, so you're not going into steroid withdrawal, which will make you feel horrible. And then second, of course, as you're coming off steroids, there's always that risk of relapse. Usually with the relapses for MOGAD, it tends to happen when you get down to 10 milligrams or less, maybe at 20, but usually if you're at those higher doses, you're okay. Again, if you do have a relapse, you have to make sure that we can confirm it's a relapse, and then we're going to have to just treat you with steroids again. And then that means the chronic immunotherapy just have to make sure that's teed up. And, let's say you're on IVIG 0.4 grams per kilogram every month, then maybe you need to be on 1 gram per kilogram every 2 weeks, or you have to be 0.4 grams per kilogram every week. Essentially, or switch medications altogether to something like tocilizumab or one of these randomized clinical trials. So I wouldn't be scared of that relapse, just be looking out for it, and then we'll find out a chronic immunotherapy that will work.
So on the pocket steroids, is that a 3 to 5 day thing as well, or is it just like a one day thing?
Yeah, so for at least our protocol, we've been doing 3 days of the pocket steroids, super high dose, followed by 11 days of just one pill, so 50 milligrams. So total, you're on it for 2 weeks. So a shorter dose than, that very first attack you have. Typically that's enough because, again, with these relapses, we're catching it so early that inflammation didn't build to, Mount Everest. We're catching it when there's this tiny little bunny hill, and we can just kind of squelch it with that amount of steroids. So that's typically what our protocol has been. And obviously with only 2 weeks of steroids, there's always a chance you might have another relapse, as that comes off. But that's been the minority of patients that we've been seeing. Usually patients have been doing pretty well.
Could you comment a little bit more about the effectiveness of B-cell depleters as the first line of treatment for relapse, particularly newer ones like Kesimpta?
Yeah, so a lot of the medications like Kesimpta, rituximab, ocrelizumab, they all work by blocking B cells, and B cells are involved in making antibodies. So you think that would be very effective for an antibody-mediated disease, and it's been proven to be very effective for NMO. For MOG, we do think it does reduce relapses, but not quite as well. There's been studies comparing NMO and MOG response, and so for rituximab in NMO, we'll occasionally see relapses, but then when they check their B cells, there are these patients that actually are making B cells again despite the rituximab. And with MOG, we've seen a lot of relapses, and we'll check the B cells, and they're undetectable. And so even though the medicine is working, the B cells are gone, they're still getting relapses. So that's why we're thinking that it's not quite as effective for MOGAD. But I suspect it does reduce things a little bit, just not nearly as much as NMO.
Got one. You had mentioned that long-term use of steroids can bring about like diabetes and a decrease in bone density. For the first time ever, I have a just barely abnormal DEXA this year, and the only thing I've done differently was take a whole lot of steroids in the month of February. Is that too recent, I think, or could that be part of it because now my internist wants me on Prolia like yesterday? I'm like, I'm going to hold off on that.
Yeah, that's a good question. So the risk of thinning of the bones, osteoporosis with prednisone and steroids it's usually more the long-term use of steroids. Acute steroid use can cause this very rare thing called osteonecrosis of the hips. Essentially, it can cause a stroke to your hip bones. Completely unpredictable. It could happen to a 23-year-old. Very rare, fortunately, but we definitely see it. It's just one of the complications that can happen. But in terms of that osteoporosis, that tends to be more long-term use, at least 3 months of steroids. And the longer you use it, the thinner it's going to get.
Hi. We're taking one more, I think, and then I have a community question.
Okay.
This is related to, I guess, just scrolled by. So one of the people who looks at our Facebook groups from the MOG Project says we see a lot of pattern where women who are postpartum sometimes report getting MOGAD. Do you believe that this is from the stress of childbirth, hormones, or something else?
Yeah, so postpartum, so essentially after pregnancy, is a potential area where patients can have relapsing disease of any kind. So during pregnancy, the thought is again, you've got a newborn kind of growing in you, which is, it's not you. So it actually suppresses your immune system just a little bit, so you're not attacking the newborn. And so the overall demyelin disease, autoimmune disease, is thought to be less during pregnancy because you're have this fetus that's growing in you. Then when you deliver the baby, then all of a sudden the floodgates are off. Your immune system doesn't have to be suppressed. So postpartum, that immediate after delivery, there is a potential increased risk for relapses. It's probably better studied in MS and NMO because those are longer diseases that we've known about longer, but we would not be surprised if that's the case for MOGAD as well. And actually, Dr. Flanagan and I were just approached about this large international study where we're going to be looking at pregnancy and postpartum for MOGAD, and the MOG project's involved as well. And so that'll be an important question to answer.